Chelsea, do you mind? Wonderful. Hello, thank you for joining us today for MVC's Health Equity Workgroup. Chelsea Andrews and I are the site engagement coordinators for MVC, and we look forward to facilitating this workgroup today. Next slide. Sorry. Today's Health Equity Workgroup will feature a presentation by Dr. Alex Peahl and Briaa Robinson of the Obstetrics and Gynecology Department at the University of Michigan. Dr. Peahl is an assistant professor in obstetrics and gynecology and a health services researcher at the University of Michigan. She recently served as the visiting scientist for Maven Clinic, the largest online digital women's and family services clinic. Her research focuses on how to improve the effectiveness, efficiency, and equity of reproductive health care through developing, studying, and disseminating high-quality maternity care interventions. She is a nationally recognized expert on prenatal care, redesign, and innovation, and has completed seminal studies and thought pieces on how to best incorporate patients' preferences and needs into right-sized prenatal care plans that match patients' needs to services delivered. She is the co-director of the Michigan Plan for Appropriate Tailored Healthcare in Pregnancy, otherwise known as MiPATH, and the chair of the American College of Obstetricians and Gynecology Redesigning Prenatal Care Initiative. Briaa Robinson is a health equity project manager at the University of Michigan in the Department of Obstetrics and Gynecology. She currently supports the promotion of health equity grants with the overarching goal to connect clinical and community partners together to improve health outcomes and eliminate disparities by creating robust systems to link pregnant and birthing people with unmet social needs to resources in their community. Thank you, Dr. Peahl and Briaa, for being here today. Before you begin your presentation, I do have some brief housekeeping items to review. First, the session is being recorded. The slides and the recording will be shared with attendees following the work group. Next, we will be monitoring the chat throughout the presentation, so feel free to add questions there. We also will have some designated time after the presentation for an open Q&A as well. And lastly, your feedback is very important to us. If you could please complete the post-work group survey in a link that will be provided in the chat right now, as well as an email sent following the work group, that would be greatly appreciated. Chelsea will go ahead and post that link in the chat shortly. Awesome. Without further ado, I will turn it over to Dr. Peahl and Briaa for your presentation. Thank you again for being here today.
Great. Thank you so much for that warm introduction, Christy. And it is so nice to meet all of you. I am going to jump right into our presentation. So just give me one moment to get those slides up and then we'll get started. Please feel free at any point to stop and share any thoughts that you have or any comments that come to mind. I hope that we can make this a conversation and not just a presentation today. And there will be some clear opportunities to hop in and provide your input as well. So today, Briaa and I are going to be talking about the social determinants of health and how we can move upstream of adverse health outcomes. I did just want to share our disclosures. I have done some consulting work and have grant funding. And perhaps most importantly, Briaa and I are both moms, and I think we bring a lot of that to the work that we do. And it certainly influenced the way that I approach this work in maternity care. So Christy did a great job of introducing us. I won't spend more time there, but I do want to introduce you to the work that we do. Briaa and I have two sort of big grants that we work on together. One is through MDHHS, and one is through the Blue Cross Blue Shield CQI Central Reserve. And across all of that work, we seek to improve maternal health outcomes through better addressing social determinants of health and bringing the patient voice into care. We do that through our Patient and Community Action Board, which is an amazing passion project for all of us. We have data and IT infrastructure to understand and support health equity. And then finally, we do development and testing in the social determinants of health space. And that's the area of focus that we'll be in today. So I always like to start with patient stories. I think that we are all drawn to this work because we want to improve individuals' lives. And so starting with their perspectives is critical. So I'm an OBGYN. My content area of focus is pregnancy, but certainly I hope that you can draw parallels to your own clinical and content areas of interest as well as we go through these examples. So if you've watched the news in the past 2 to 3 years, you have heard that we are in the midst of a maternity care crisis in the United States and particularly in Michigan. And that morbidity and mortality has traditionally been seen as a medical issue that hospitals need to solve. Here are 3 examples of that morbidity. The first patient has a postpartum hemorrhage after her birth. There's difficulty controlling bleeding during the time of her delivery. She needs extra procedures, a trip to the operating room, and ultimately a blood transfusion. The second example is a patient with severe preeclampsia or high blood pressure of pregnancy. This patient comes into the hospital with extremely high blood pressure, signs of kidney damage, and difficulty breathing from fluid on her lungs, all known complications of that high blood pressure. She's admitted for the rest of her pregnancy and ultimately needs to have her baby early, leading to the resulting not only maternal morbidity, but also neonatal morbidity. And our final patient has a postpartum infection. She comes in 3 days after birth with fever and chills, and she's found to have a severe infection because a portion of the placenta was still inside her uterus. These all seem pretty clearly in the inpatient realm. But if we think about maternal morbidity a little bit differently, we see that much of it is preventable and often is driven by unmet social needs. So the CDC released a report earlier this year suggesting that 80% of adverse maternity care outcomes can be prevented. And much of those preventive measures need to occur far upstream of the birth hospitalization through routine prenatal care delivery and addressing those barriers to care that are affected by social needs. If we go one step up from our patient with a postpartum hemorrhage, we see that she actually had trouble attending all of her prenatal appointments. She missed her laboratory tests in the 3rd trimester to check for a low blood count. And so no one noticed that she had anemia, and she was at greater risk of transfusion entering her birth hospitalization. For the patient who presented with severe high blood pressure, she lost insurance between her pregnancies. And when she became pregnant again, she didn't have good blood pressure control. Additionally, there was a missed opportunity for aspirin. She did not receive counseling that this intervention that could reduce her risk of high blood pressure by 90% should be administered. And so we see the downstream effects. And finally, for the patient with a postpartum infection, I think many of us can identify with this experience. Her prenatal visits were rushed because she had to get back to work. So she missed out on important education about warning signs. And so rather than presenting at the first sign of an early infection, she came in really sick with complications of that infection later on. Addressing birthing people's unmet social needs is critical for improving their outcomes, and this starts with screening and addressing social needs in prenatal care. You can imagine the first patient may have made it through her birth hospitalization with no complications. Her blood counts could have been optimized, and that bleeding would not have been so devastating. Patients could enter pregnancy with well-controlled disease if they have adequate insurance coverage and access to care between pregnancies. And finally, receiving excellent counseling can help patients to be partners in their care, recognizing early warning signs and preventing before complications are severe. So I want to pause for a second with our first community question on the webinar and ask, what health outcomes does your group seek to improve? And how might they be affected by those upstream social determinants of health? And you're welcome to either use the chat, or if you want to unmute and share a little bit of your perspective, that would be great. If you don't mind, just in your text chat sort of saying who or what organization you're representing, that will just give us helpful context. So I'll give folks a second to contribute. And certainly Christy and Chelsea, if y'all want to jump in, you're welcome to as well. Great, thank you, Kelly. So you're representing a PO, and any of those health outcomes that y'all are focusing on right now that you can take one click back and identify some potential social determinants of that. Great, you've got Munson represented. You know, this is a really tough question to think about. It's different from how we traditionally think about healthcare. Social needs have sort of been in someone else's lane or someone else's realm. Reducing all-cause readmissions. Oh, this is such a good one. Can anyone offhand, oh, perfect, yeah, start to identify those other social needs that might contribute to all-cause readmissions? Access to prenatal care absolutely is one of those big contributors. Transportation, limiting follow-up appointments. With all-cause readmissions, I could imagine food insecurity influencing wound healing and leading to more complications. ER returns being a reflection of access to care. This is such a great start. Thank y'all for participating. And as we go through the next slides, you're welcome to keep putting those outcomes in, and that'll help us to sort of keep everything together in our thoughts about these social needs and how they're affecting the outcomes we care about most. All right, so our team likes to use this conceptual model to think about social determinants, or as they're now more commonly being called, social drivers of health and how they affect health outcomes. So these play a significant role. Over 80% of health outcomes can be attributed to those upstream factors. And currently, we have patients who present for care, have unmet social needs that are not identified. And these unmet social needs limit care access, just as y'all highlighted in the chat, but also directly impact outcomes and can lead to those adverse outcomes we all care about so much. So addressing only medical care really misses these key opportunities to address the most impactful drivers of poor outcomes. I have often heard when I've presented, social needs are just an issue for patients with Medicaid. But actually, a survey we did of over 200 patients, half who had commercial insurance and half who had public insurance, showed that social needs are prevalent regardless of your payer. About 2/3 of commercially insured patients and 90% of publicly insured patients reported at least one unmet social need. So this is really an important driver of care for everyone. So addressing social needs starts with assessment. We can't treat what we don't know. And so when a patient presents for care, assessing for social determinants of health is that key first step in the process. Once social needs are identified, the most common pathway is assistance or providing linkage to care resources. So for the patient with transportation insecurity, providing a ride voucher or perhaps having a van service pickup. And ideally, that assistance resolves the social needs and leads to improved outcomes. Better access to care and addressing complications can improve outcomes, for example. But there's also another care pathway that we can think about for improving outcomes, and that's care adjustment or making changes so that care is more accessible. This adjustment improves access and then in turn can also improve outcomes. So an adjustment for transportation insecurity might be offering virtual visits or clustering services together so that patients can come one time and receive all of the labs and imaging that they need. So walking it through, a patient has transportation insecurity, and the traditional method of not assessing social needs, we might not identify that social need until a patient doesn't show for visits. For us, prenatal visits, often we see that drop off after that initial visit. And when patients don't come in, they're missing those important services and having poor outcomes that potentially could have been mitigated. Instead, if we identify the need, we can provide assistance so they can get to the critical services that they need. And we can provide adjustment to make care more accessible while we await for the resources to be able to address that underlying transportation insecurity. So I think that this is pretty intuitive, and yet it is not reliably being done currently in pregnancy care. And so our work really seeks to address these gaps in addressing social needs in pregnancy across the 3 domains: improving assessment, helping to facilitate assistance, and then demonstrating new ways of adjusting care to make it more accessible while we wait to improve access to services for all patients. And so let's start with assessment. We first wanted to understand what was going on with care assessment for social determinants of health in pregnancy across the state. And we started with the Obstetrics Initiative, which is one of the Blue Cross CQIs that has 68 participating hospitals. We did a cross-sectional survey of QI leaders at each hospital. This was administered through the Michigan Hospital Association. We just wanted to understand baseline, what was happening. I do want to highlight that this survey was done at the hospital level, and so it does not reflect the nuance of outpatient practice, but was a good first step in just understanding at baseline how was screening being completed. We divided social needs screening practices into 2 categories. One is systematic, regularly completed assessments, for example, every week or done annually, and then sporadic screeners, those hospitals that did not have any screening approach defined, or that just did screening at random times or when a need was identified. And here you can see those 2 classifications and what categories went into the systematic screening and the sporadic screening. All 68 participating hospitals completed the survey, and we found that 73% were doing some screening, but of those, only 40% of hospitals were systematically screening, whereas 60% were doing so in a sporadic way. We looked at a variety of hospital characteristics: hospital size, academic center, presence of a NICU, presence of DE&I teaching, and no hospital level characteristics were associated with systematic screening, suggesting that really any center is able to do this task. Here you can see how screening was completed at these hospitals. So the most common method was through patient-completed questionnaires. Others used a provider assessment, either through a provider screening tool or through a history and physical exam and regular capture. And the other options you can see down here. And then here are the times that screening was done. So for the systematic screening group, at every clinic visit was the most common, or at regular timed intervals, followed by annual health maintenance visits. So why are these screening rates so low? I think there are a few key themes that have emerged as I've asked folks about this across the country. We did a national listening tour with the American College of Obstetricians and Gynecologists, in part to understand how to better incorporate addressing social needs into routine pregnancy care. And these are some of the summaries from our conversations with over 110 individuals across 25 different organizations, including patients, advocates, providers, payers, and policymakers. The first is knowledge. Many clinicians are not trained to manage these social problems and don't feel ready to help if a need is identified. The second is resources. Clinicians are incredibly concerned about what to do if they screen and don't have a matching resource to assist. We know that clinicians are overburdened right now and feel they can't add one more thing to add to their practice, so time is a significant barrier. We also heard a really important ethical query, their ethical dilemma that individuals were facing, feeling like it's unethical to screen if you don't have anything to offer. And then finally, the existing screening tools were burdensome, many over 20 questions, and providers felt that adding another questionnaire may be challenging in the current clinical environment. So for this last issue, the issue of screening tools, my team, when I was working at Maven Clinic, actually developed and tested a short form screening tool. We tested it in over 200 pregnant and postpartum people. And this short form tool was developed from from Prepare, one of the gold standard social needs screening tools. We also, in this survey, asked questions about patients' experience of social determinant screening and management to better inform screening practices. And so we had this tool, which we validated compared to Prepare, and then we also asked quantitative and open-ended survey questions to get into this idea of how to best address unmet social needs in care. Here you can see the short form screening tool. This tool takes less than 1 minute to complete. You can see on the left, it asks about mainly material needs, and then on the right, some of those more social-based questions. And we found that the short form tool performed pretty well, about 80% sensitivity for detecting any need. And this was in a population, as I mentioned before, with a fairly high prevalence of unmet social needs in the population. So not a perfect tool, but it did perform fairly well, and certainly would perform better than not screening at all. I think one of the most important findings from this work was that people wanted to share their social needs. Over 80% believed that it was important for their care team to know about their social needs, and over 80% were comfortable sharing these needs. And we did not find any difference in comfort for screening by method, including SMS, app-based screening, or in-person screening with either a clinician or a lay person trained to access these needs. Another important finding from this work was the concern that screening without careful attention to historical inequities could further risk alienating already marginalized groups. In particular, participants who were Black or had unmet social needs preferred asynchronous screening, which seems to reflect the comfort that individuals have with asynchronous communication and not having that concern for bias or stigma in the screening process. The second important finding was that participants with unmet social needs worried about how reporting those needs could impact their ability to parent. Specifically, they worried that sharing their unmet social needs could lead to Child and Family Services involvement and potential loss of their ability to parent their child. This highlights the need for supportive counseling and sharing why teams are screening. You can see some direct quotes, which I think are really powerful on the right-hand side. One patient said she was afraid that social services could possibly try to take her child, and she was worried that it could cause me to lose my child, even though it's not my fault and I'm doing the best I can. So this is the language that we have used in our social needs tools, which we call resource-first screening, starting with why we're asking the questions before actually asking patients to disclose information that may make them feel vulnerable. The other question I hear a lot, and we saw in those barriers to screening, is the concern that screening without assistance is not ethical. We saw that most participants were open to sharing their social needs even without tangible available assistance. Over half were willing to do so. And importantly, when you define assistance more broadly, that comfort likely goes up. Patients expressed that empathy and checking in were actually a form of assistance, and said that they would hope that their provider would just be there to listen or would continue supporting them in their health decisions. When we think about adding adjustment to these care pathways, this adds yet another way of intervening, even when tangible resources aren't present. So to summarize, current screening for social determinants of health in pregnancy in the state of Michigan is limited. It can be done efficiently through a variety of modalities. Patients want their care teams to ask, and screening requires sensitivity, particularly for historically marginalized populations. And finally, assistance is not the only way to address unmet social needs. So I'll pause there for any questions about assessment of social needs. Great. And then I would love to just briefly ask in the chat, how are social needs currently being assessed in your patients or the practices that you work with, if at all? I'll give folks a moment to contribute. I will say we just launched social needs screening at Michigan Medicine for our pregnant patients. We started last November with a pilot and then expanded shortly after. And we're using the Partners in Care questionnaire, which was developed across the state. So I see typically assessed in offices with a patient-completed questionnaire. Great. Thank you so much, Irene, for contributing. Any other approaches to social needs that folks want to share? Annual screening with referral to community resources. Perfect. Thanks so much, Diane. So it sounds like some good systematic methods. Great. And then employing their own care managers to do this kind of screening and referral. That's excellent. All right. Well, feel free to continue using the chat, and I will keep going now and actually hand it over to Briaa, who's going to go over some of our efforts in helping to develop the assistance pathway.
Thank you, Alex. Can everyone hear me okay? Okay, great. Okay, great. So I will talk a little bit about what we've done. At least you can actually go to the next slide. Thank you. No. I'm going to talk a little bit about what we've done through our pilot in Kent County. As part of our Health Equity Initiative, we are collaborating with HealthNet of West Michigan, who is a community organization focused on connecting patients to resources, and our clinical partners, the University of Michigan Health West Women's Health Clinic, which is a mouthful. And the ultimate goal with our partnership is really to connect pregnant people with resources that are in their community with unmet social needs. Next slide, please. And so a lot of questions we get are around, how do you build a social needs program like this? And so Alex and I put our heads together and realized there were 6 main things that we've done over the last year to launch and pilot this project. And I'll say the first and most important is the relationship building. So meeting to set a regular cadence of meetings to establish those mutual goals and to build rapport is really important. And also being able to meet in person is really critical. Secondly is stakeholder identification. So identifying those people that need to be at the table for each step and creating those work groups to get the work done. And we found that stakeholders can include not only those that are making the decisions, but those people who are actually doing the work or that the decisions will impact the most. Thirdly is around this process planning. So developing the roadmap for ideal processes and then troubleshooting as much as possible. And if possible or feasible with a smaller subset of people or patients. Fourthly, you have developing and launching the training materials. And of course, making sure everyone who touches the process knows about it and has input. Most times this will be the stakeholders or additional people, again, that may be impacted by these changes. Next is the data collection. So identifying, establishing existing work streams and how to access the data. And this may also include connecting with your legal team, depending on if you need data use agreements, but also having that conversation just early in the process to eliminate any pushback or delays that may happen with not being able to get that data. And then lastly, launch, evaluate, and improve. So figuring out a checkpoint time to sit down with your stakeholders and determine what is working well and what can be better optimized. Next slide, please. And so here's our current project workflow with our project. So as Alex kind of reiterated in the beginning of this presentation, step 1 is the assess piece. So right now we have our nursing team completing the initial screening with all birthing people presenting to the Healthy Pregnancy Clinic during intake. And so this Healthy Pregnancy Clinic is a subset of patients that the clinic has identified first-time moms or people who would benefit from that additional support. During that screening, they also connect them with HealthNet. So they describe what's going to happen, what the goal is of this connection, and whatnot. Step 2 is the connection piece. So once the social needs screening is done, the nursing team incorporates that into the patient's EPIC chart and their problem list. And then that completed screening is faxed over to HealthNet. HealthNet then creates a case and assigns a case manager to support the patient. Step 3 is the assistance piece. So HealthNet, again, connects to the patient and provides any additional resources or support that is needed at that time. And then lastly, Alex iterated this a little bit earlier, is the adjustment piece, so the follow-up. So HealthNet sends a report about each of the patients that the nursing team sends over. Any additional resources that are provided is then added to the patient's chart. And there's that communication. So if there's any care adjustment that is needed, whether, as Alex mentioned earlier, the patient identifies transportation as a barrier, the provider then knows this and can adjust as needed. Next slide, please. And this is just an example of the language that we use when presenting this to our patients. So it's pretty quick, but again, just highlighting, what are we doing this for? Identifying those social needs. What is the time commitment? Most patients want to know. They don't want to spend a lot of time doing this. So the screening takes less than 5 minutes. And then how can it benefit the individual? It's a connection to low or free resources. And then there's absolutely no cost to the patients. Next slide, please. And this is just a screenshot of the social needs screening tool that we're currently using at the clinic. And again, this covers 9 topics around social determinants of health. I'm not going to read through them all, but we did want to just show you guys what we're using currently. Okay. And then here's our lessons learned. So we've been in the throes of this for about a year. And so we wanted to sit back and figure out what have we learned and how can we make future pilots and projects better. So relationship building takes time. And again, consider doing the first or multiple of your meetings in person to, again, facilitate that rapport. Secondly, around stakeholder identification, determine who needs to be at the table and how to get them there as early as possible in the process. That will prevent having to discuss goals or meeting materials and things of that nature. Thirdly, when it comes to process planning, communicate those expectations up front. We found that when we get that information out to the team, it really builds trust and understanding as we move through this process. Next, around developing and launching training materials, just make sure to get input from all stakeholders and give them plenty of time to review, and of course, set deadlines. When it comes to collecting data, again, just discuss as early as possible data use agreements. These can get pretty complicated if you have to include your legal team and other decision makers in the process. And then lastly, but not least, launch, evaluate, improve, and celebrate. Celebrating wins and showing gratitude to the team has been really critical for us and a good thing to continue to, again, establish a relationship and trust. I'm going to stop there and just see if there's any questions before I turn it back over to Alex. And you can either just jump off mute or just, again, pop the questions in the chat. Okay, hearing none, thank you guys. I will turn it back over to Alex.
All right, everyone. So I'm just going to move on to the next part of the care pathway, which is adjusting, or really thinking about how we can modify care to be more accessible for our patients. So sometimes there are just not social needs resources available currently. And while many organizations and state-based groups are really striving to make that possible, we run into these issues where we can't actually meet the unmet social need. The first is that the resources might just not be known, and a clinic just starting these processes needs time to establish those community connections. The second is that there might not be resources available for all needs. While there are great pathways for food insecurity, for example, or for transportation, there aren't clear resources for social isolation or utilities. And then finally, there are some areas where there just are not resources. In particular, when we think about rural or remote areas, we've been hearing from our colleagues practicing in those settings that finding resources can be quite a challenge. But even if we don't have assistance, patients have needs. And when we don't acknowledge them, it leads to patients feeling unheard and not supported by their care team. This is one quote from our work where a patient who had unmet social needs that weren't identified said, "They don't care at all and they don't even ask." So on the national level, we're actually working to modify prenatal care delivery to better address unmet social needs. And we're doing so through a new prenatal care plan called the Plan for Appropriate Tailored Healthcare in Pregnancy, or PATH. And when we do PATH in Michigan, we call it MiPATH, just so that that terminology is a little more familiar. PATH is a new national recommendation. It's been developed from existing evidence and rigorous consensus methodology with 19 maternity care professionals from across the country, as well as key group input to improve the efficacy, efficiency, and equity of prenatal care. And all of those goals are accomplished through tailoring care delivery to patients' medical and social needs. This graphic demonstrates sort of the overview of PATH. So when a patient presents for care, she receives screening for both medical and social determinants. We then solicit and incorporate patients' preferences to determine this tailored care plan, tailored in 3 key areas. The first is visit frequency and monitoring. How often are patients come to clinic, and what is the cadence of those visits? For patients with more intense medical needs, that may be a 12 to 14 visit schedule, whereas for someone with less intense medical needs, that could be 8 to 9 visits over the pregnancy. The second category is telemedicine and care modality. For some patients, telemedicine visits can help provide flexibility while maintaining contact with a maternity care professional. And there are really just poor anchoring visits that must be delivered in person because of the need for in-person services like laboratory testing or ultrasounds. Other visits can potentially be done remotely as long as patients have a blood pressure monitor at home and they're beyond the point where they can verify fetal viability through sensing fetal movement. Other modality adjustments include group prenatal care. So someone who has social isolation may derive dual benefit from group prenatal visits where they can receive their medical care and also the support and education through a community. And then finally, support for social and structural determinants of health, making sure that patients receive the additional assistance that they need and any care adjustments to meet those unmet needs. And so I wanted to walk you through what this might look like in real life, because I know this can feel a little bit nebulous. So I'll introduce you to 2 patients. The first is Maya. Both Maya and the next patient are based on sort of compilations of many of the individuals that I've cared for in my practice. So Maya is a 31-year-old G2P1. That means that she's had 1 prior birth and she's currently pregnant. And she just took a positive pregnancy test after she noticed she was really tired chasing her toddler. She and her husband, Devin, are really excited for their son to have a sibling, but they're also worried about juggling 2 kids and their busy work schedules. Her social needs screening shows she has difficulty with childcare and balancing work and medical appointments. But medically, she's uncomplicated. So for Maya, a more flexible care model makes sense. She has few additional needs in pregnancy, and so her care plan is designed to be minimally burdensome. Here you see yellow visits, which represent her in-person visits. The pink visits represent potential virtual points of contact for her. And then this orange visit is her anatomy ultrasound, which is typically done at 19 or 20 weeks. Maya's able to do remote monitoring with a blood pressure monitor. She actually works in a doctor's office, so she can just check her blood pressure at work. For education, she just wants information through the portal and has a pregnancy app that she used before that she finds helpful. And for her wraparound services, she really leans on her family and coworkers and doesn't feel she needs additional social support. Let's compare Maya now to Taylor, who's a 26-year-old G1, so first-time mom. She just took a positive pregnancy test after her first missed period. She and her boyfriend are really excited but nervous about this unexpected pregnancy. They just moved to Michigan for a fresh start, and they don't have any friends or family nearby. Her social needs screening shows that she has transportation insecurity. She and her partner are trying to save up for a car, so they have 2 vehicles, but currently they share one. And she also is experiencing social isolation with her move. Taylor also has chronic hypertension, which has been well managed, although at the move she hadn't established care, and so her blood pressures are high on her first visit. And so Taylor needs a more intense care model. You can see here all of these yellow boxes represent in-person visits for her, and she doesn't feel comfortable with telemedicine. She really thinks she'll benefit from being in person with her physician. This increased contact also provides additional opportunities for wraparound services for her non-medical needs. Ideally, her transportation and security will be assisted with another vehicle, but for now she receives assistance through ride vouchers that help her to make it to all of these appointments. She has a blood pressure monitor at home to keep close track of her blood pressures. She has all kinds of different educational offerings to support her. She also joins an online pregnancy support program to help with her social isolation and sees social work to see if there are additional resources she can receive. So I think that care adjustments are really challenging for us to think through as healthcare professionals. We're very used to thinking about the services we need to deliver, but not so much about how we might deliver them differently. And so telemedicine, group care, targeted visit schedules have all been tools in my tool belt to adjust care. And I'm curious what adjustments could be available to make healthcare more accessible for the patients that you and your organizations are serving, to start to help those really big problems that your groups are trying to address, things like hospital readmissions, ER presentations. You know, it's really tough to sort of think with the magic wand and change how we currently do things. I think an interesting example from maternity care was many years ago, the birth center struggled with capacity for birthing patients, and a reduction in the length of stay was seen as a really advantageous method for increasing the ability to care for the people who needed to come into the hospital and give birth. So rather than have patients stay in the hospital for 3 days, once they were medically cleared to go home on day 2, they returned to their home, and a home nurse actually was available to visit them, help with infant feeding, help with self-care, and check in. So it was adjusting care from the hospital setting to home. It's an example that benefits the hospital system, but you could imagine similar services that might help if a patient has children at home and is struggling with childcare during an admission, bringing some of those hospital services out of the hospital room into the home could potentially be an adjustment. I see in the chat more use of telehealth. Started with the pandemic, but then being successfully maintained. Absolutely. For maternity care, I think the silver lining of COVID was this huge acceleration of telemedicine and flexible care that had been on our 10-year roadmap for improving the accessibility of services and changing care delivery. And suddenly we launched truly overnight. So I love that example. Mobile health clinics. Yeah, please, Briaa.
I was just gonna mention that Karen also suggested more locations.
Oh, thank you so much. Yes, so bringing care closer to individuals' community and even thinking about alternative places where that care can be delivered. In our focus groups, folks talked about how libraries or other public gatherings could potentially be sites for telemedicine where devices were available, or even could be remote sites for care. I love that. Thank you, Briaa, for keeping me on top of the chat. Did anyone else want to contribute to potential care adjustments? Well, I hope it got the wheels turning. Excellent. All right, well, we'll just wrap up with a few slides on where we're going. So how do we keep improving social needs for pregnant people and their families? So as I mentioned, our work really seeks to fill existing gaps in social needs practices. And the first gap that we've identified that I find surprising every time I say it is we actually don't know all of the locations where prenatal care is being delivered across the state. And so if you want to improve care delivery, you have to know where it's being delivered. So we are planning to conduct semi-structured interviews across the state of Michigan to identify current practices and the gaps in current social needs services being offered. And we're really thrilled to partner with MVC to help to identify all of the clinics linked to their vast network across the state and make sure that we're incorporating all of the important voices that need to be there. The result of all of those interviews will be a mom map, a comprehensive resource across the state to help inform future initiatives. We hope to identify what practices exist and where, who they are caring for, and who's providing those services, and then understand the assess, assist, and adjust pieces that are currently available within these practices and what's needed to help promote each of those arms. After the completion of the mom map, we will be convening social needs change agents from across the state in a social needs conference to really bring together those clinical and community partners and build a better future for pregnant people and their families across the state of Michigan. So this is our vision graphically. We currently have the Kent County pilot ongoing, and we are doing the exploration and preparation work through focus groups in other sites across the state to really understand the barriers and facilitators to these programs. And from those exploratory focus groups, we'll be building out additional pilots this year. Simultaneously, we'll be completing the mom map to understand additional sites and what's currently being done in the state. And that will be used as the foundation for future projects, which we hope will cross populations in the state broadly. All of our work is informed at every stage through diverse representatives from the clinics, and also with input from our patient and community action board to make sure we're asking and answering the questions that matter most to patients and the people caring for them. So thank you so much for having us here today, for your participation, for your insights. It really was such a pleasure to get to share our work and hear the overlap with y'all. And we're happy to take any final questions.
Wonderful. Thank you so much, Dr. Peahl and Briaa, for your presentation. Does anyone have any questions before we conclude today? Wonderful. Well, I can include the contact information for Briaa and Dr. Peahl in the follow-up email if you have any questions. And if you have any questions for MVC as well, we'll include our contact information as well. I will go ahead and share my screen again to conclude the work group for today. I'm just going to share some upcoming events with you all. Wonderful. So thank you again, Dr. Peahl and Briaa, for presenting today. That was an extremely informative presentation. Before we conclude today, I wanted to review some upcoming events for MVC. The first thing that I'd like to make note of is that we do have our fall collaborative-wide meeting being held on October 20th in Lansing, Michigan, from 10 a.m. to 3 p.m. And this meeting will focus on health equity, health disparities, and interdisciplinary collaboration. So we hope to see you there for this in-person meeting. Our next work group we have for October is a preoperative testing work group, and that will feature the Michigan Program on Value Enhancement, otherwise known as MPROVE, on October 26th. And then starting in November, we have a diabetes work group on November 2nd, and that will feature Holland PHO. So thank you again. As a reminder, today's work group slides and recording will be shared following the work group. If you have any questions, please reach out to us. Additionally, if you or someone you know may be interested in speaking at an upcoming work group, please contact the MVC engagement team via the email listed on the screen here. Thank you once again for your support of MVC, and we look forward to seeing you at future work groups. If you could please complete that survey, that was posted in the chat earlier. It will also be included in an email following this work group. That would be greatly appreciated. Thank you so much again, and have a great rest of your day.